Thank you, Mr. Chairman, and to the ranking member for organizing today's hearing, and to the panelists for joining us. I want to get back to a question that was raised earlier about the role of the VA system going forward, and a question raised by MITRE and Dr. Giraud, the letter that you signed to the Secretary on September 1, suggesting that it is worth looking into whether or not the VA should focus on specific areas of service-related conditions. And in some of the things that we've heard from the Secretary about the 34% utilization rate today, and that for each additional percent of utilization, it costs the VA, I think $1.4 billion was the number that we got from you. And that's 34% is just of those veterans who are currently enrolled, doesn't include all eligible, which I believe is 9 million, or all veterans in the country over 20 million. So from a fiscal perspective, it's hard to make the case that the VA should provide all care to all veterans all the time. I just don't know how we could do it fiscally. I think there's some very serious operational concerns that are self-evident to everyone here. And then on the moral dimension, we really have a crisis in mental health care. When officially we know that 22 veterans a day are taking their own lives, and most veterans organizations that I've spoken to think the real numbers is certainly much higher than that. And when we know that care delayed becomes care denied, turns into tragic outcomes for veterans and their families, I want to ask you and Mr. Byrne and the secretaries about this question of prioritization. Should we be prioritizing in the 41,000 funded but unhired positions within VHA, mental health providers? Should the VA become a center of excellence, as I think is suggested in the MITRE report, or one of the issues that we should look at, so that perhaps 100% of eligible veterans who have post-traumatic stress disorder, are suffering from the consequences of traumatic brain injury, have military sexual trauma, have traumatic amputations or other significant combat and service-related conditions, they go to the VA because it's a center of excellence, there are no access issues, and we prioritize hiring and resources there. And when we refer people out into the community, we refer them out for conditions that are comparable to what the general population has, whether that is diabetes or the flu, or someone looking at audiology or your feet, or any number of other conditions that are comparable. Tell me, I'll start with you, Dr. Giraud, what's wrong with that conclusion, and why the Commission has not reached that already?
Thank you for the question, and there were so many statements that we do support very strongly what you said. Among the first point, I think it goes back to aligning resources with demand, and the VA in some aspects is an impossible situation because the demand could literally double overnight, depending on how the services are provided and the demand for the veterans. And that's an impossible situation to plan for X, 2X, or 3X, and you know the numbers as we outline them. So to specifically define what the VA is going to do, to fund it specifically for that, and to provide other sources of care for the remaining is the main point. We have to align demand with resources, however that's defined, and it can be done 2 or 3 different ways. They can all work, but you need to pay.
Is some demand more important than other demand? So if a veteran is coming back from Afghanistan with post-traumatic stress disorder and cannot get in to see a mental health care provider, isn't that more important?
So I'm not going to say more important, but what I will say, which is the essence of your question, sir, is the panel, the Blue Ribbon panel does feel, and I think it is true, that there is care for these kinds of specific issues: post-traumatic stress disorder, traumatic brain injury, traumatic amputation, severe burns and injuries, that nobody on the planet does it as good as the VA.
Right.
And it needs to be comprehensive care, not just in the operating room, but all the social services, the mental services, the comprehensive provider care that needs to be done. And certainly, at the essence, that is something the VA, among all things, needs to be preserved for. Whether the VA should take care of every patient with hypertension or diabetes or other issues is a question that needs to be resolved by the governance. But clearly, those core issues are something that our veterans rely on, will rely on, and the future injuries of war that we cannot predict, the VA must always be there for that, in our opinion.
I'm out of time, so I'll have to follow up with the other panelists at a future date, but I would certainly love to sit down and talk with each of you and get your responses to the
We look forward to that opportunity. We have 8 classifications today that help sort through some of that, and we'd love to sit down and go through it with you.
Thank you. Thank you, Mr. Chairman.
Dr. Abraham, you're